Okay, so imagine my surprise when I woke up this morning and I found about 6 inches out our back porch. So we're going to be covering some of the endocrine disorders today, and I'm going to look at what is the most important thing a nurse needs to know about them. So the endocrine unit objectives you can read on your own. So the first patient we're going to take care of is Jack Sparrow. He was admitted to the hospital with splitting headaches. We can see his height and weight. His skin is cool and moist, and that should be a clue to us that there's something wrong here. His heart rate's 110 and his blood pressure's 220/100. That would be another clue. Now, instead of saying, oh my God, look at that blood pressure, the thing that we should be looking at is look at that heart rate. For patients that have hypertension, we would not anticipate seeing a heart rate of 110. So we're starting to think maybe there's something wrong with him that's not hypertension related, but instead maybe endocrine related. So we got our Jack Sparrow's orders. We have bed rest. We have labetalol, 1 milligram per kilo. The first thing we're thinking of, labetalol, beta blocker. Okay, beta blocker blocks beta 2 and does have some beta or alpha. So when we're looking at that, we're looking at maybe a pheochromocytoma. He had a CT of his abdomen and he's NPO. What else do we want? We probably would want something for his headache because we know that he has a headache and he also has a high blood pressure. So we can see the CAT scan. We got this big old mass there. Thank God for red arrows because you can see it. And his metanephrines are really high. So you ask, what are metanephrines? Metanephrines is the breakdown of catecholamines, specifically epinephrine. So we know that he has a pheochromocytoma, which is a tumor inside the adrenal medulla. And with that tumor, it's going to be just shooting out epinephrine all the time. Patients with a pheochromocytoma have episodic hypertension. So when we look at this, when we're doing some vital signs and whatever, we would see that one time his blood pressure may be 130/90, and then it shoots up to 220/110, and then it comes down. It's very episodic. This can be related to medications. It can be related to diet. And it's also, in Jack's case, he has a tumor. So when we look at this, we can see, wow, that's a really big tumor there. If we remember from our anatomy class, the adrenals are about the size of our fists. They sit on top of our kidneys, and we can see that this one is pretty big. It's probably the size of our fist. So he's got a lot of epinephrine being excreted. So they remove this tumor, and now what do? Well, we know that the adrenal glands are highly vascular. So the one things that we would need to do would be to do vital signs very frequently. One of the other things that is really disconcerting with having a tumor this size, or any size really, is that because it's vascular, we would also need to be assessing for any bleeding. The other thing is that with the tumor this size and the constant release of epinephrine, we would need to be doing vital signs again to make sure that we have that we're seeing a decrease in those that blood pressure. Teaching, he's going to have a lot of epinephrine running around his system. So we're going to need to be teaching him that when he gets home, just because the tumor's been removed, we're going to need to be watching for more bleeding. And we're going to need to watching for hypertension. Once that epinephrine is gone from his system, the other kidney or the other adrenal gland will start taking over, and it should produce enough for both adrenal glands. So teaching, he's going to need all of that post-op teaching. He's at risk for DVT, so he's going to need to wear TED hose. He's going to need wound care. He's going to need to be watching that wound. He's going to be assessing for fever, make sure he doesn't have an infection, etc., etc. So our next patient is James T. Kirk. He was admitted to the hospital after his family found him in bed and they were unable to arouse him. And then again, we're looking at those vital signs. Number one, we see a hypothermia. So hypothermia, first thing I think of is my thyroid. Thyroid regulates temperature. It also regulates our heart, carbohydrate metabolism, fat metabolism, protein metabolism. And look at that heart rate. It's 34. Respiratory rate is 8. That's pretty slow. And then we have a low blood pressure also. So the family reports he has a history of hypothyroidism. He's been increasingly tired and sleepy for days. When we assess him, we can see that we have some periorbital edema, which is expected, dry, flaky skin, hypoactive bowel sounds, hypotension, bradycardia, bradypnea, and we also have that, again, that hypothermia. We also see that he has a hair loss, although he really doesn't, because look at that hair. He's already got some hair loss. He's an older gentleman. So we look at his vital sign, or his laboratory values. We can see that that TSH is really high. Do you need to know the level or what a TSH is normal and T4? No, don't worry about it. But you can see that we have a really high TSH. And we have a really low T4. So the pituitary, which is kind of regulates all of our endocrine function, we can see that it's telling the thyroid to produce. But unfortunately, the thyroid says, nah, I ain't working. So what would we, excuse me, what would we anticipate from our healthcare provider? Well, we can see that his glucose is low. And again, thyroid regulates glucose metabolism along with our insulin. It also regulates carbohydrate metabolism. So he's going to need some type of glucose in his IV. What kind do you ask? Well, I would anticipate that he would have some 10% dextrose or a hypertonic solution. We also see that his sodium's low. Again, we're not going to mess with the sodium because until we get that thyroid fixed, the sodium's going to fix itself. With that sodium being low, again, I would anticipate having some seizure precautions on the bed. I would have him close to the nurse's station because he may be confused. We already know that he's really lethargic. So some of our nursing diagnosis, we may have some hypothermia, we may have some fluid and electrolyte imbalance. We would also, we have impaired nutrition greater than body requirements. Some of our interventions are going to be, like I said, seizure precautions, keep them close to the station. We're going to be administering glucose. So we would want to be doing some AccuChecks. We would anticipate from our healthcare provider what this man needs is some IV levothyroxine. So he begins to arouse after we give our first dose of IV levothyroxine, and he says that his levothyroxine is really expensive and he stopped taking it. We know that with levothyroxine, you have to take it every day. We would need to, when you stop taking it, now remember, levothyroxine has a half-life of about 6 days. So he probably stopped taking it 3 weeks ago. Some of our interventions, I would personally contact case management, because if he can't afford his levothyroxine and he needs it every day, we need to figure out some way to get him on it and keep him on it. We would teach them about the administration of levothyroxine, remembering again that he needs to take it every day, first thing in the morning with a glass of water. He doesn't, should be on an empty stomach, and he should not be skipping doses. So Catherine Janeway is another one of our patients. She was admitted to the hospital with complaints of dizziness, weakness, and constant urination. Her only medical history was a motor vehicle accident 1 week ago. We can see again that she has a heart rate that's over 120. Her blood pressure is 86/40. And the clue here is that she had a motor vehicle accident. She had a bump to her head, I'm sure, because what she has is diabetes insipidus. So when we look at diabetes insipidus, we can see lab values. Sodium is 162, calcium is 9.6. But the thing with this is we need to look at her serum osmolality. So her serum osmolality is 380. We know that normal is about 280, 275 to 295, 280 to 295. So she is really dry. And her urine osmolality is really low. Now, again, you don't need to know urine osmolality. I just put it in there to show you that she's really dehydrated. So what's happening here? She had a bump on the head. It stimulated her, or it hurt her pituitary gland. Excuse me. Rather than releasing antidiuretic hormone, she has no antidiuretic hormone. So she's she's excreting all of her water. So she's really dehydrated. We would anticipate from our healthcare provider, we would want some normal saline at first, get that blood pressure up, because we know it stays in the intravascular space. And then probably some D5 and water, because her little cells are probably so dehydrated and we need to fluff them up. Some of our nursing interventions are going to be, first of all, we need seizure precautions. We want to put her close to the nurse's station. We want to monitor that INO. We want that daily weight. We need to maybe give her, the doctor probably is going to order some synthetic antidiuretic hormone, or called DDAVP. We're going to need to be teaching her how to administer her DDAVP. And that's it.